Assalamualaikum, we are from Group 9. The topic for our group is healthcare, subsidies and insurance coverage. Okay, I will start with the executive summary. As a developing country, Malaysia has made a good progress in the healthcare sector with a dual system that includes public and private healthcare services. This report examines the challenges arising from Malaysia's dual healthcare system, which comprises both the public and also private sector. That's how we continue with the issue summary. Malaysia has a two-tier healthcare system comprising a government-funded public sector where medications are heavily subsidized or free and a self-funded private sector where patients face high out-of-pocket expenses. An indication showed that 87% of Malaysians use private healthcare, which leads to a significant cost, while only 13 get free medications from the public facilities. Furthermore, the decision between public and private hospital in Malaysia often reflects a patient's socio-economic background and personal preference. In contrast, private healthcare offers faster and more personalized services but at a significantly higher cost.
In Malaysia, the government gives healthcare subsidies so everyone, especially the B40 group, can get medical help. People only pay small fees like 5 ringgit to see a specialist, while the government covers the rest. But there's a gap. The B40 group uses public hospitals, while the T20 can afford faster, better private care. This creates unfairness even though everyone pays taxes. Rawls' theory says the system should help the least advantaged, but long waits and limited services still hurt the poor. From utilitarian view, subsidies are good because they improve health for many, but if the system grows too fast, it may not be sustainable. Programs like Peka B40 and My Salam try to help but not everyone knows about them. So, to be ethical, the government must not only give subsidies but also fix the system so healthcare stays fair, equal and strong in the future.
I will be presenting 3.2 subsection 1, which is insurance in Malaysia. There have two main types, which is private insurance and government insurance. Initiative purpose for this is provide financial protection against health issue, property damage and other risks. For private insurance, it's offer health, life, auto and property insurance, which funded through policyholder payments and not government support. For government insurance, they provide initiative for B40, which is first we have My Salam, free takaful protection scheme for eligible B40 individuals. And second one is Peka B40, which is the target B40 individual age 40 and above, offering free health screenings, medical equipment, assistance, and cancer treatment incentive. Lastly, they provide with transport subsidy. For 3.2 subsection 2, which is ethical dilemma, is conflicting moral values in healthcare forced difficult decision, which is rising costs, make essential treatment inaccessible to low-income individuals. Many forgo routine check-up or emergency care due to high out-of-pocket expenses. Insurance company may deny coverage based on exclusion, lack of pre-approval or non-network provider. And then the financial interest take precedence over patient well-being. It debate among policymakers on universal healthcare or regulatory measure for fairness, affordability and ethical integrity. For 3.2 subsection 3, which is Malaysia Healthcare System Overview, these are public healthcare that tax-funded, heavily subsidized service across all care levels. Universal health coverage, which is UHC, aims for universal healthcare accessibility. The challenges for it: long wait times, overcrowding, resource constraint, aging population, rising medical costs. For private healthcare, it's more quicker access and specialized treatment, advanced technology and more higher costs. And the affordability is for concern for lower income groups. The issue for it: high premiums, moral hazard, innovation, efficiency and competition.
3.24 Apply ethical theories. This presentation explores the ethical framework behind the healthcare coverage, highlighting the contrast between utilitarianism and Cantonese technology. It emphasizes the moral responsibility of a government to ensure the access to medical necessary care, guided by the principle that healthcare is a fundamental right, not a commodity. Private insurance firms are expected to be ethical by providing fair, transparent coverage and avoiding profit. 3.24 Virtue Ethic. This session emphasizes that virtue ethic, rooted in Aristotle philosophy, focus on the moral character of healthcare and insurance provider. It's argued that true ethical behavior is not about following rules or changing outcome, but about embodying compassion and reliability. Compassion means fair, not discrimination, and accessibility coverage, especially for vulnerable population. Reliability means maintaining trust throughout the honest, medical transparency, and respectful treatment of the patient and policyholder. 3.26 Concept of the right-based ethic, moral hazard, and stakeholder responsibility. This session explored the ethical principle of the right-based ethic, moral hazard, and stakeholder responsibility in healthcare and insurance. Right-based ethic asserts the individual are entitled to essential protection like a financial security, access to healthy care, and informed choice. However, this idea often clash with an insurer financial consideration, creating ethical dilemma when the care is denied for the budgetary reason. Moral hazard arises when the patient, provider, or insurer take advantage of the beings from the risk, leading to higher costs and potential misses of the service. Lastly, stakeholder responsibility emphasizes that all patient, company, employee, client, and investor share the duty of the uphold ethic standard throughout fairness, transparency, and accountability.
Subsidies are money from the government to help poor people like the B40 group to get the hospital care. They aim to be fair. On the other hand, insurance is a plan people pay for like My Salam to protect people's money if they get sick. So the problem with subsidy is too many people using the system, while problem with insurance, some people cannot afford it. But both try to make healthcare cheaper. But with subsidy, people don't overuse care because it's based on income. So with insurance, people may overuse it since they are covered. So in short, both help but in different ways. Malaysia has two main health systems, which is public subsidy and private insurance. The government helps everyone, especially the P40 group, get basic care. Programs like My Salam give money support when people get sick. But there are still problems. The rich T20 can get private care easily while the poor B40 may face delay. Some people don't know what help they can get, and it's hard to run this program well. So Malaysia wants to give healthcare for all, but it's still working on making things fair. Ethically, the country shows good values like social responsibility and equality, but better policy and stronger actions are still needed. In Malaysia, we use a mixed system with both government help and insurance. It gives support to poor through schemes like My Salam, but there are still problems like delays and rural area having less access. So in the UK, the NHS is fully funded by the government. It gives fair access to everyone. However, people often face long waiting time and limited resource. In the US, the system is market based. People have more choice and new technologies, but the system is too expensive. Many people cannot afford care, and inequality is a big issue. Each country has a good point and challenges based on their values and system.
I will be presenting an analysis of Malaysia's healthcare system using the PLUS ethical decision-making model. Under the policy element, Malaysia's public healthcare subsidies align with national goals and WHO's UHC missions. However, private insurers often diverge due to profit motives, leading to coverage gaps, especially for low-income groups. From a legal perspective, schemes like Masalam and PKB40 are protected by law, yet inconsistent regulation in private insurers can result in rejected claims, raising doubts about fairness and ethical compliance. On the universal front, essential care is accessible to all, but subsidies mainly benefit the B40 group. Resource and regional disparities to limit for universality in healthcare access. Lastly, under SAF, the government upholds its ethical duty by promoting equity. In contrast, private insurers often face a dilemma between profit and public health responsibility, weakening their ethical image. In this final reflection, we look at the future challenge and ethical policymaking in Malaysia's healthcare system. As the country modernizes, several ethical issues demand urgent attention, such as a rapidly aging population, rising non-communicable disease, high healthcare costs, and over-dependence on government subsidies. These include both urban and rural communities, ensuring equal access through better treatment quality, increased
transparency, and smart use of digital technologies. In short, ethical reforms is not just about policy, it is about protecting lives and securing a healthier, more just future for all Malaysians.
Lastly, the ethical lesson that can be learned is that there should be a equity in access of healthcare. The high price of medication in Malaysia's private healthcare highlight the ethical dilemma between making equal access to healthcare available and ensuring that public resources are taken care of. For example, campaigning for privatised healthcare will tend to make Malaysia's healthcare system more unfair. Overcharges within private care can perpetuate health inequalities, which affect those who cannot access public care due to long waiting lists or specific health needs. Lastly, based on utilitarian perspective, the ethical issues were faced, like how high private healthcare costs may reduce overall societal well-being.